And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Good morning, dear colleagues. In those very sporty satellites and virtual all over Africa, wherever you join us from. My name is Dr. Barbara Engelsmann. I work for PATA and I speak to you from beautiful Cape Town. I am so pleased to welcome you to our Africa Cafe 5. Today is all about advanced HIV disease. The prime session this morning already covered some important aspects of advanced HIV disease: epidemiology, definitions, country strategies, treatment optimization, long-term management, rights perspective. So quite a bit of ground has been covered already. Being out there at the forefront, dealing with AHD and very sick patients can be a daunting perspective, even more so if we're dealing with very sick children. And this is why we dedicate one Africa Cafe just to this topic: how best to prevent, screen for, diagnose, and treat advanced HIV disease in children and adolescents by age group. I have the great pleasure of introducing our one and only speaker for this Africa Cafe, Dr. Rita Oladele. Dr. Oladele is an associate professor and clinical microbiologist at the Department of Medical Microbiology and Parasitology at the College of Medicine in Lagos, Nigeria. It would be easy for me at this point to fill the next few minutes with Prof. Oladele's titles, achievements, positions, and affiliations. But let me just say this: Prof. Oladele is nothing short of a guru in the world of invasive fungi. And with many of the opportunistic infections that we see in advanced HIV disease being of fungal origin, Cryptococcus, histoplasmosis, PCP. What better expert could we have here with us to speak to us on managing children and adolescents with advanced HIV disease? Prof. Oladele's presentation has been pre-recorded, but she's going to try to join us live a little bit later for Q&A. As Prof. Oladele has much to share with us on the topic of how to manage AHD in children and adolescents, we may not have a lot of time for Q&A after the session. So we will try and answer what we can, but also please make sure to post your email address in the chat together with the questions, and we will then try to respond to your question by email if we don't have enough time for it in the session. And now, without any further ado, sit back and enjoy Dr. Oladele's presentation. Thank you.
Good day. I especially thank the organizers for giving me the opportunity to speak at this very important summit. I'll be speaking about managing children and adolescents with advanced HIV disease, pathways and strategies. So WHO has defined advanced HIV disease for adults and adolescents and children older than 5 years is pretty straightforward. Is that any child, any of these individuals is classified as advanced HIV disease if you have CD4 count above 200 cells per cubic millimeters or a WHO stage 3 or 4 event. And this includes both the ART naive individual and those who interrupt treatment and return to care. But all children under the age of 5 with HIV are considered as having advanced HIV disease, although there's a caveat for those that have been on ART for over a year. So I tell stories a lot because I found that stories leave a lasting impression. People can easily forget data you present, but they never forget the stories you tell. So I want to talk about this Nigerian child with advanced HIV disease that we made a diagnosis of cryptococcal antigenemia in. Well, a 16-month-old female child that presented with complaints of progressive weight loss of about 3 months duration, cough of 1 month, fever and passage of watery stool, and dyspnea of 1 week duration. The child had a positive history of contact with an adult with chronic cough, the mother. The mother had antenatal care, was unsupervised. Delivering was done at home. This child was breastfed till 2 months before presentation. She had BCG immunization 2 weeks after birth. The mother had never had HIV testing done prior to this presentation in the hospital. On examination, we found an acutely ill dyspneic child with both tachycardia, both tachypneic, okay, and having tachycardia. And the child also had widespread coarse crepitations bilaterally and was febrile. Oxygen saturation level at room air was low, 84%. And child also had oropharyngeal thrush. Anthropometric measurements were all low for her age. HIV antibody screening for both the mother and the child came back positive. Stool was collected from the child and gastric aspirate for gene expert, and both were negative for Mycobacterium tuberculosis. Cryptococcal antigen testing was done because the facility I just recently commenced AHD package of care for the adult population, so the crack test was available. So it was done for this child and it came back positive. However, we could not do lumbar puncture on the child. Child was really ill looking, so flexing the child and all that was not in the immediate plans. Suspension of fluconazole 8 mg per kg was commenced, but unfortunately the child died by 4th day of admission. This was a preventable death. Epidemiologically, WHO, I came across, I thought to share this WHO recent document looking at HIV statistics, and you can see that children, that's less than 15 years, about 1.45 million of them are among those that living with HIV/AIDS. That's about 4% of those living with HIV/AIDS. And then, however, 84,000 of them are estimated to die from HIV infection. So there are a staggering 130,000 new infections each year. About 30% of this will still die from opportunistic infections like TB, pneumonia, diarrhea, malnutrition, and this is unacceptable. So despite the fact that we have had significant progress, okay, in scaling up ART treatment for children, for adults, there have been gaps in children, and this has been associated with fatal outcome. I'll give you some statistics. We see that children that are living with HIV make up a disproportionate proportion, okay, of the advanced HIV disease-related mortality. And you can see from this that you have, for the people living with HIV/AIDS, children just account for 4% of them. But look at it, they account for 15% of the mortalities. This is disproportionate. And then when you look at this data, you see that 53% of children versus 68% of adults are on ART. And then 30% of people living with HIV/AIDS still present to care with severe immunosuppression, that's advanced HIV disease. And then 50% of the first AIDS-defining events and death occur within 6 months of ART. This is both for adults and children, but it's worse in children. And then you have mortality among children initiating ART is high. And this is especially so in sub-Saharan Africa. So bacterial infections and AIDS-defining events are the main drivers of hospitality, of hospitalization in children globally. Okay, we have data from Uganda and Zimbabwe have found that 36% of children present to care with advanced HIV disease, stage 3, stage 4 event. So opportunistic infections, severe acute malnutrition, these are the drivers of hospitalization, of morbidity and mortality in children that have advanced HIV disease. So research would need to set up research, do proper research to address these drivers and to find where the gaps are, so that this research should be translational, so that we can prevent this, because these are actually preventable deaths. You can see data here, the cause of mortality. You have TB, yes, pneumocystis pneumonia, bacterial infections, bacteremia, okay, bacterial pneumonia, diarrhea. All these are treatable infections. So these are deaths that are preventable. So more needs to be done to understand the AHD burden among children. And I advocate that we should have improve access to care, improve the access. Each country should come up with guidelines for the advanced HIV disease population in children. And then those guidelines should address to be able to identify the gaps in the management of these children. CHI, that's Clinton Health Access Initiative, has recently been the forefront driving this. Okay, and I came across this publication where they said, facing advanced HIV disease in children and adolescent health zone, findings and recommendations from a landscape assessment across. So they looked at 3 African countries, of which you have Nigeria, Uganda, and Zimbabwe. And for me, what was striking here was the fact that the AHD population amongst children, if you see in children less than 5 years, 82% in Nigeria, 45% in Uganda, and 78% in Zimbabwe, okay? And then for the older children, It was a little bit less, but still alarming. And then when you look at the infections, you have 4% for TB in those less than 5, where you have 23% in those between 5 and 9 years, and then 10 to 19 years, you have 18%. Then cryptococcal meningitis, we have just 1% in the less than 5 years, 3% in 5 to 9 years, and then you have 4% in children above 10 years. And then for pneumocystis, no data. Is it that it's not occurring? No. It's that we lack diagnostics for it. Severe bacterial infection, no data, 0. Is it that it's not occurring? No. It's that nobody is looking for, we lack diagnostics for it and the capacity to make them, both infrastructurally and skill set. Histoplasmosis, the same thing, no data. But interestingly enough, we have a paper that showed that children accounted for a significant proportion of the advanced of the histoplasmosis cases, not HIV-infected children, because most of this data was before the advent of HIV/AIDS on the continent. But children accounted for a significant proportion of reported cases. So WHO agreed that there was a problem with children and that this was a gap in ensuring that we end AIDS death by 2030. So they came up with a WHO pathway. It's called Stop AIDS, okay? And they published this in 2020. So it's the package of care for children and adolescents with advanced HIV disease. It's called Stop AIDS. And it's strictly, Stop AIDS strictly stands for S for screen, T for treat, O for optimize, P for prevent AIDS deaths. So we're stopping AIDS. So how do we go about it? Screening, you can screen for TB, you can screen for cryptococcal, antigememia or cryptococcal infections, malnutrition, okay? And then treat TB, severe pneumonia, bacterial infections, cryptococcal meningitis in older children, severe malnutrition according to WHO guidelines. And then we optimize rapid ART initiation within 7 days. For the adolescent population, you must screen for opportunistic infections first, and then antiretroviral therapy counseling. And then you can prevent bacterial infections and pneumocystis by giving prophylaxis. Currently with cotrimazole, there's some data research ongoing that might advise inclusion of azithromycin while awaiting that study. And then cryptococcal preemptive therapy for cryptococcal meningitis in cryptococcal antigenemia positive patients with fluconazole, and then vaccinations with pneumococcal. For vaccination also have been known to be preventive, so you can vaccinate for pneumococcal disease, HPV, measles, and BCG. So that's the pathway that WHO is advocating. So we'll start with screening. You know, it was the first one, the S. It's a screening, diagnosis, and preventive components of the package of care, the WHO package of care. So screening and diagnosis. So we want to screen for TB. You can use a clinical algorithm. I'll go in details with that because TB is particularly important because some of the high-burden TB countries globally are in sub-Saharan Africa. So we screen for TB using clinical algorithm alongside with radiological findings when indicated and if it's available. So ideally, GeneXpert and GeneXpert Ultra is advocated as the first by WHO. So you can use induced or expectorated sputum. It can be done on stool. It can be done on gastric aspirate, nasopharyngeal aspirate, or any other extrapulmonary specimen. Okay. The other thing also is TB LAM, the LF LAM assay. Okay, so you can see that both for those under 5, for all age groups, it's advocated, both these two. But I will discuss them further in subsequent slides. Cryptococcal antigen screening is advocated for just the older children. That is because data from South Africa showed we were more likely to see more cases in children above from the age of 10. However, in country Nigeria, the first case I presented, there wasn't a neonate. So we might miss some might slip through the cracks. So if you have a strong index of suspicion, don't forget these are recommendations, but if you have strong index of suspicion, please go ahead and you could do the crack test too. So samples to be used include serum, plasma, whole blood, okay, and then you could do lumbar puncture, so cerebrospinal fluid. And then preventive measures are prophylaxis and preemptive therapy. So vaccination is there. For the conjugate pneumococcal conjugate vaccine, the catch-up for children less than 5 years is mandatory. Cotrimazole, like I said, for bacterial pneumonia, okay, and pneumocystis pneumonia, it's advocated in all age groups for the AHD patient. And then TB preventive treatment, it's also advocated for age groups. And then you have fluconazole preemptive therapy. It's not advocated. That is for those that are crack positive, and it's the older children that are screened, the adolescents. So now for TB screening, we want to look at adults and adolescents. So I want to start with the older children, the adolescents, right? So children above the age of 10 to 19. So you can screen these people with any of the following symptoms of TB. If they have any of these symptoms, so current cough, fever, weight loss, or night sweat. If it is no, they fall into the category that you want to look at giving preventive, that's TB preventive therapy, okay, TPT. So you assess for contraindications, okay, to this preventive treatment. And how do you assess? You want to ask the following questions. You ask the patient or the guardian, do you have any known history, or is there any known history of chronic hepatitis, viral or otherwise? Okay. Do you have any known problem with hepatitis right now? Have you ever been told you have a problem with your liver? Do you drink alcohol daily or regularly, or drink heavily? Do you have any problem with sensation? That's peripheral, you're assessing for peripheral neuropathy, right? So tingling sensation, numbness in the feet, in the hands, or elsewhere in the body. If answers to these questions are no, you can go ahead and give preventive therapy. However, if the answer to these questions is any of these questions is yes, you want to defer preventive therapy. You also screen for TB, okay? But at the same time, you want to assess for other things. So screen hepatitis and all that, you want to do all that testing, okay? Now we'll go back here. If you now have, if you have that the patient had clinical signs, this clinical signs, symptoms, and then the answer to this is yes. You ask patient current cough, that's NT more than 2 weeks, fever, weight loss, night sweat. If the answer is yes, you want to investigate for TB and other diseases. And I think I would like to emphasize here other diseases, because it's not only TB that will come out with these signs. So it's important that we don't lock ourselves in a box and just think TB, because that's one of the problems we have in Africa. If it is not TB, it has to be TB. So you want to look at possibility of other diagnoses. So you want to screen for other things like invasive aspergillosis. You want to screen for histoplasmosis. A number of other disease entities actually mimic this. So If it is, and then you want to also screen for TB. So for TB, you could do microscopy, okay, AFB staining. You could do GeneXpert, like I said, which is standard for WHO right now, either using GeneXpert or GeneXpert Ultra. You want to look at also doing the TB lab. We'll discuss those further, but those are the tests you want to consider. Okay, microscopy is not so sensitive, and you need a skilled microscopist. The challenge you might have with TB lab is that if the patient is not symptomatic, could it be it's a disease? So let's leave that. If the patient is symptomatic and TB lab is positive, you know this patient, and it's something that somebody can be trained on, the equipment can be installed, okay? Although your microscopy probably better in your for field work and all that, but the samples can also be pulled and can be sent directly to a site. So if there's a spoke and hub model where you can have from peripheral hospitals can send to where the samples can go to the hub, so that the GeneXpert can be done and the results communicated back. The challenge is that we want as much as possible. You know, one of the stop parts is to optimize treatment. So you want as much as possible start ART within 1 week. So if you did the test and it's negative, despite the fact that this patient is symptomatic, and you screen for other diagnoses, if you have other organisms that other infections causing the infection, you give the appropriate treatment and you consider this patient for preventive therapy, but look out for drug-drug interactions. If it is not TB and it's not other diagnosis, you want to follow up and consider preventive therapy also. But if it is positive for TB, Mycobacterium tuberculosis, you want to treat for TB, following the country's TB guidelines or the WHO guidelines. But for all these other ones that are negative, as often as they come in contact with a healthcare worker, they should be screened for TB regularly using this same algorithm. So at every follow-up appointment, patients that are on preventive therapy should be asked for adverse effects. It's critical that we ask that, because these are some of the things that drive compliance. So you want to ask the patient, have you lost appetite, or you have no appetite for food? Okay. And then, have you been tired of feeling unwell? Have you had an upset stomach or stomach cramps, nausea, vomiting? Have you noticed any yellowing of your eyes or skin? Have you had dark colored urine or light colored urine? Have you had any rash or itching recently? Do you have any numbness or loss of sensation anywhere in your body, particularly on the palms and on the feet? Because all these things you need to check for. If they say yes to any of these questions, you want to pause, stop the treatment, and investigate further. So it's a little bit more tricky for infants and children? So children and infants and children living with HIV who have poor weight gain, fever, or current cough, or who have a history of a contact with an adult or so an individual that has active TB should be evaluated for TB and other diseases that could cause similar symptoms. So if the evaluation shows no TB, then these children can be offered TPT regardless of their age. In children less than 1 year or infants less than 1 year of age, they should be given preventive therapy only if they have the history of a contact with an adult or individual with active TB. And they have also been screened for active TB, which have been excluded, then they can have preventive therapy. But if they are screened and they are positive, they need to have full TB treatment. And children and infants living with HIV should be screened. This screening for TB should be routine at every contact with a healthcare worker or a visit to a health facility. Okay? And this is regardless of whether they are receiving TB prophylaxis, that's TPT, or if they're already on antiretroviral therapy. So this algorithm comes in very useful for children more than 12 months living with, that's more than a year living with HIV. Screen for poor weight loss, poor weight gain, fever, current cough, history of contact with someone with TB. If it is no, assess for contraindications like we have done in the adult, any yellowness of the eyes, any itching, all those, right? And then if the answer is no, you can give preventive therapy. If the answer is yes, defer preventive therapy and investigate further. And I always say in this, it's better to get in the specialist, okay, to review. And if the answer is yes, so that the thorough investigation can be done. And then if you investigate for, if the answer is yes to any of these symptoms, clinical presentation, you want to investigate for TB and other diseases. So you want to look at possibility of other diseases, and if it's confirmed, you give appropriate treatment and consider preventive therapy. If it's negative for Mycobacterium TB, okay, follow up and consider preventive therapy. It's ideal, and at every follow up, please screen for TB. Do the same screening for TB. And then if it's positive for Mycobacterium tuberculosis, you treat for TB. Then I came across this very recent article published in July this year. It was looking at TB screening for children. It was a meta-analysis, very detailed. And I thought it was good to, I adopted this algorithm from there. So it's for children that are less than 10 years with symptoms suggestive of pulmonary tuberculosis. So you look for presence of danger signs. Maybe patient is dyspneic, hemoptysis, and all, you want to stabilize, transfer, or both as needed. So you can transfer to a tertiary facility where we'll get optimal care. Especially if a child is going to be needing oxygen or high dependency care unit care. Okay, but if you have facilities for that in your facility, you can place on oxygen. You have a specialist pulmonologist to review. You can retain, okay, and investigate further. So if the child is younger than 2 years, living with HIV or severely acutely malnourished, so this is an advanced HIV disease child altogether, who has CD4 count, a child less than 5 years, okay? And if the answer is yes, you want to go ahead and collect respiratory or stool specimen for GeneSpark or GeneSpark Ultra, and then for children living with HIV, you can actually urine TB lab if it's available. If this is performed, and then you have to detect Mycobacterium tuberculosis, if it is performed or not performed, the result is not yet available. You want to also find out, is there any exposure to close exposure to somebody that had chronic cough or TB in the previous 12 months. If it is no, you can actually use an algorithm that they developed, a scoring algorithm, where they say cough more than 2 weeks is 2 marks. If it is fever longer than 2 weeks, you have 5, and then you score, and then you get your total. Radiological findings also you score. So if they have cavities, enlarged lymph nodes, and then you have opacity, okay, miliary pattern you can see gives you 15, okay, and then you score. So if the sum of A and B is more than 10, you want to initiate TB treatment. This algorithm is useful in settings where you don't have the advanced package of care for children already in place. So it can be useful when you use just X-ray findings to go ahead to initiate treatment. However, we advocate that the advanced HIV disease package of care be put in place in any facility that has, and then especially in high areas of high incidence like sub-Saharan Africa. The TB lamp for sick patient, WHO also came up with this recommendation for the sick child, for the stable child, and adolescent. So WHO strongly recommends that you use the TB FM lamp to assist in diagnosing active TB among children and adolescents living with HIV. So if they are HIV positive, it's strongly advocated if they have signs and symptoms suggestive of TB, both pulmonary and extrapulmonary. If they have advanced HIV disease or they have stage 3, stage 4 event. And then regardless of signs and symptoms of TB, if they can fall into the classification of advanced HIV disease. So it's a strong recommendation. But for stable children, so for sick children, TB lamp is strongly recommended. However, for stable children and adolescents, WHO suggests that we should use TB-LF lamp to assist in diagnosing if the child or the adolescent has signs and symptoms. We're looking at an ambulatory child, right? Or adolescent has signs and symptoms of TB or is seriously ill looking. So regardless of symptoms, when they have a CD4 count less than 100, they already fall within the classification of advanced HIV disease. So it's suggestive, WHO suggests that you could use TB lamp to make a diagnosis, CD4 count less than 100. WHO also recommends against, but WHO is against you using TB lamp, TB-LF lamp to assist in making the diagnosis among children. If you have not assessed for TB symptoms, and if the child is without TB symptoms and the CD4 count level is unknown, or without CD4 count levels, or without TB symptoms and the CD4 count is greater than or equal to 200 cells per cubic millimeter. Okay, so without TB symptoms and with a cell count of 100 to 200, you still are not in a hurry. WHO recommends against using TB-LF lamp. So what are the preventive strategies? Because really we don't want the child to progress to TB, okay? So WHO has come up with a number of preventive measures, and this is from the Stop AIDS document. So it says you can give preventive therapy of daily isoniazid, is the drug of choice for children living with HIV, especially those that are less than 5 years. But you want to add pyridoxine, that's vitamin B6, to prevent peripheral neuropathy. Another option is 3 months of daily rifampicin and isoniazid. So it's 3 months if you are using a combination of rifampicin and isoniazid. For children that are on ART with no drug-drug interaction with rifampicin. Okay, child-friendly dual drug, that's both rifampicin and isoniazid, fixed dose combination is available for children up to 25 kg. And then you could also give weekly rifampicin and isoniazid for 3 months from 2 years of age children who are on ART with no drug-drug interaction with rifampicin. And however, there's no child-friendly formulation that's available for this. So daily rifampicin and isoniazid for 1 month can be used for adolescents who are on ART and when there's no drug-drug interaction with rifampicin. So this preventive therapy has been shown to reduce morbidity and mortality among children with HIV. And older ones, even if they do not have a known TB contact. So TB preventive therapy is not currently recommended for infants less than 12 months unless they have a known TB contact. So you cannot treat children, you cannot give preventive therapy for infants unless they have a known TB contact. And that's a close contact. So that's TB. So for other preventive measures, you can give preventive dosage of drugs for children based on the weight band a daily administration, cotrimazole, like we said before, for both pneumocystis and pneumocystis pneumonia and bacterial pneumonia. Okay, isoniazid we have already discussed, and then fluconazole for the older children when you are looking at preemptive therapy for cryptococcal meningitis. And also you could also use it, cotrimazole, when they have oral thrush. Sorry, fluconazole when there's oral thrush. So this is the treatment algorithm, treatment monitoring algorithm that was recently updated in 2021, and it shows you that you should have routine viral load monitoring for early detection of treatment failure. It's essential. Okay, so we need to obtain and review results by 6 months after. So after the patient, first and foremost, for the older child, 10 years and above, you want to, they practically fall within, also mirror the advanced HIV disease package of care for the adults. So you want to screen. In fact, for the children, you must screen for opportunistic infections because of the challenge of iris, especially in TB and meningitis. So you want to screen for opportunistic infections before you commence ART. That is to prevent development of iris. Okay, the other ones, the other infections, you want to treat them or you want to prevent them so that your ART can really be effective, because if these infections are on, it further drives the immune suppression. So it's when you are screened for opportunistic infections and you want to start ART within a week. If the patient is TB positive, you cannot. You need to defer ART for 2 weeks. If it's the older child that's cryptococcal meningitis, that's cryptococcal antigenemia, the same thing for just 2 weeks. But if it's cryptococcal meningitis positive, that's you did a lumbar puncture and it's positive, you want to defer for at least 5 weeks, 4 to 6 weeks before you initiate ART. But after you have initiated ART, you want to repeat your viral load. So you want to repeat, but you need viral load monitoring to monitor response. So you want to repeat viral load at 6 months after ART initiation, and then 12 months after ART initiation. So 6 months, 6 months, and subsequently after that, you want to do it yearly. If you haven't done this monitoring and you go ahead to repeat, and it becomes that on the viral load, the viruses are undetectable at less than, you are having less than 50 copies per mil, you want to maintain the current antiretroviral therapy. Okay. However, if the viral load is more than 50 to 1,000, between 50, more than 50 to 1,000, okay, you want to provide enhanced adherence counseling, and then you repeat that viral load after 3 months. If it is more than 1,000 copies, you want to switch regimen, and you switch to appropriate, and this will be dependent on your country's regimen. Okay, guidelines, what your country guidelines says. And then if after testing at 3 months, it becomes undetectable, you monitor the sentinels. After adherence counseling and viral repeat testing at 3 months, and it becomes undetectable, you maintain the regimen, drug regimen the patient is on. If it's still more than 50 to 1,000, you want to maintain it, but continue enhanced adherence counseling and repeat viral load testing after 3 months. And if it is more than 1,000, you want to switch to another therapy, and that will be dependent on your country's guidelines. And then adherence counseling should be provided at all visits to ensure that viral suppression is maintained or given priority throughout care. So vaccination is another preventive measure, another preventive strategy that has been adopted by WHO and should be adopted countrywide. I'm sure it's in all countries' guidelines. So you have BCG should be given to neonates born to mother of unknown HIV status. WHO advocates that you can give, if the mother's HIV status is unknown, you can vaccinate. But neonates that with unknown HIV status but are born to mothers that are HIV positive, you can vaccinate. But neonates with confirmed HIV infection should delay BCG vaccination until ART has started. I hope that's communicated. Born to mothers of unknown HIV status, vaccinate. Neonates with unknown HIV status born to mothers that are HIV positive. So the HIV status of child you don't know, but that of the mother is positive, it says vaccinate. Neonates with confirmed HIV infection, you should delay BCG vaccination until ART has been initiated. For measles, you want to look at potentially susceptible and asymptomatic children that are living with HIV. If they are not severely immunosuppressed, that they are not advanced HIV disease, then you can vaccinate. But if they fall within HIV, they fall within the advanced HIV disease classification. The guidance is not too clear there. Okay, so it's important that this is reviewed again. And then in areas with high incidence of both HIV and measles first, the measles first dose should be at 6 months. So if you have high incidence of HIV in a region and reported cases of measles, the first dose should be at 6 months, then followed by 2 additional doses up to 2 years of age. So if the CD4 count cell level was, CD4 count was low when child was first immunized for measles, and additional dose should be administered when immune reconstitution has been achieved. That's the CD4 count cell percentage reaches 20 to 25, or 6 to 12 months after you have initiated ART. And then the catch-up pneumococcal conjugate vaccine for children younger than 5 years. So children younger than 2 years should be given priority to receive this catch-up doses because they are more at risk. Unvaccinated children aged between 1 to 5 years should receive at least 2 doses separated by at least 8 weeks. For unvaccinated children, 2 doses separated by at least 8 weeks. And then for infants and preterm neonates living with HIV who has received their 3 primary vaccine doses before 12 months of age may benefit from booster dose in the 2nd year of life. Then for the hepatitis, the HPV virus, it's for adolescents. And then, so children that are living with HIV, once they reach adolescent and become sexually active, are at the risk of acquiring HPV infection. So evidence indicates that that's the human papilloma virus. So evidence indicates that for the adolescent females living with perinatally acquired HIV, have a higher prevalence of high risk human papilloma virus infection. They have the higher risk of acquiring the infection, so they need to be vaccinated. So the quadrivalent HPV vaccine is safe and highly immunogenic in both boys and girls with HIV. So it's advocated that they are vaccinated with the quadrivalent HPV vaccine. Now I'm going to go to a gray area. We recently published this data showing that 7.5% of advanced HIV disease patients, these were in adults, okay, that met the adult definition of advanced HIV disease and were symptomatic with symptoms suggestive of TB. 7.5% of them had probable disseminated histoplasmosis. And this data, and we also had this paper that has been published in PLOS ONE neglected disease that shows that we have quite a significant number of people in Africa, even before the advent of HIV/AIDS, are being managed, being diagnosed with histoplasmosis using the histopathological, that's histology result. So Africa, some regions in Africa are actually endemic for histoplasmosis, but the diagnosis is being missed. Okay? And we have been able to establish this. And in my country, Nigeria, and we are advocating that screening should be done for this. Is it there in the pediatric population? We don't know. But like I said, the advanced HIV, the paper in Plus One neglected disease, showing that histoplasmosis was a neglected disease in Africa, showed us that most of the reports of histoplasmosis on the continent, a significant number of them, were from children. But this was before the advent of HIV/AIDS. Okay, and then we are also going ahead to look at literature and found that the same thing, we don't really know what the picture is like in children. So it's a gap that needs to be addressed. But I'm not advocating that it should be your package of care. But you should have it at the back of your mind that histoplasmosis is a disease that commonly mimics TB. So when you are having your gene expert or TB lamp positive, think outside the box. It might be something else. It could be histoplasmosis. So there are other strategies. I've given the WHO pathway that have been advocated, but there are other strategies that we could look at. I came across this very interesting paper that looked at adherence counseling in children. I said it's found that children who received diagnosis of their HIV status reported improved ART adherence compared to children with no disclosure. And that we needed innovative interventions to promote progressive disclosure of HIV status, okay, to improve children's ART adherence. And I'm one of a strong advocate of the fact that children, and I think we need to educate their parents also. So it's also in the place for the counselors to advise, to educate parents that children need this information. They can understand, they can relate with it. And then, so it's part of what I will advocate. I mean, this possible other strategies I'm talking about. So you can look at, we want a situation where we strengthen the coordination of the package of care. So one of the things we noticed from the package of care from the adults and adolescents in country is the fact that there was this fatigue on the part of the healthcare workers, data collection officers, that it was running in parallel with the routine programs. So they saw it as an additional program being added. So we want a harmonization. Let the advanced HIV disease package of care be part of the ART package that is already on ground, so that there's strengthened coordination of this package for both screening, treatment, and prevention. And it's also critical that the TB program of the country is also brought in when you're initiating the advanced HIV disease package of care for children, so that there's harmonization. We don't need to have this separate program, but each one can complement each other and strengthen the program. And it's important that these are included in the country's national guidelines and protocols. It's essential that we expand access to advanced HIV disease package of care for pediatrics across countries. We need to promote integrated service delivery. I think I can't overflog this. And there must be political will. So I always say that one of the things that drives political will is data. So if we can integrate this and come up with robust data showing the burden and the challenge and the interventions that are needed, I think it can push political will. We cannot overemphasize capacity building. So we need to retrain on advanced HIV disease package of care on the role of screening, preventive therapy, okay, treatment of advanced HIV disease packages for pediatrics. I will need to do those trainings and retrainings again. Of course, increased access to diagnostics. It's nice to think about it, but the world has gone beyond just thinking about it now. We need diagnostics. There are a lot of point-of-care diagnostics on ground. You have the crack test. It's a point-of-care test. In 10 minutes, you get results. We'll still have the same thing for histoplasmosis. Even for your CD4 count, you have the Visitech. You can get your CD4 levels in less than 2 hours. Okay, so did I say 2 hours? Yes, less than that you can have it. So you could actually decide to initiate ART treatment for the naive or recommence treatment for those that are returning to care once you can determine what the CD4 counts are. So there are a lot of point of care tests available and more are being developed. And then we need educational tools. We need, especially for the older children, even for the young ones, we can come up with cartoons, we can come up with information booklets for information sheets for parents. Okay, children can do things like videos, comics, games. You can set up clubs for them, patients club. We've discovered in other disease entities that when we have patients group, fora, even if it is online, it tends to be very supportive and drives adherence to therapy. So active and complete surveillance data collation and regular review, not yearly review, regular review is essential because you need this data to be able to drive political will. So adherence counseling for all ages is needed and cannot be overemphasized. So together we can tackle children, we can take care of children with HIV/AIDS and stop AIDS deaths in this population before 2023. We could actually give children hope. So we need to start free, make sure that they start HIV free. And for the older child, they can stay free, the virus free, and AIDS free by stopping advanced HIV disease. I thank you for listening, and I'm interested in your questions, so let the conversation begin. Thank you.
Thank you, Prof. Oladele. I'm not sure whether everybody can see me and hear me. I hope you enjoyed Prof. Oladele's presentation as much as I did. I think we can just see her in her teaching function. I definitely could hear her. Wow. You've done true justice to this rather complex and large topic, Prof. Oladele. Thank you very much. I know we are running short of time. I know we are running short of time, but I would like to sneak in one question at least for you to answer, and the others we will try and address by email as much as people have left their email addresses with the question. So I have one question here from Cameroon. Thanks, Prof. Oladele, for this great presentation. I see that CD4 plays an important role in making diagnosis for AHD in adolescent and children, but now there is a challenge with the availability of CD4 count tests. Can children presenting with other infections and without CD4 count test be classified as AHD?
I think that's a really tricky question, but let's not also forget that apart from CD4 count, which we strongly advocate and which is strongly coming back into the program really, but without CD4 count, we could also go ahead if a child is ill, WHO clinical staging, right? So if it's stage 3, stage 4 disease, then that child falls under the qualification of AHD.
Thank you. This was a big session, a lot to take in. and I understand that we all have our own and very different clinical settings that ultimately dictate what diagnostic and treatment options are available. But I hope that this session has brought to the forefront of your minds the importance of this topic, because we have it in our hands to end pediatric HIV. Thanks for your attention, and I hope you're enjoying the last day of our PATA Summit. Thank you.